At 5 o'clock one morning, Mrs. Kelly, age 67, sat on the toilet and strained, but nothing happened. She decided to drink coffee and try again later. An hour passed with no result. By noon, a dull pain had begun in her lower abdomen and spread toward her back and hips. Her stomach felt tense, her body felt hot, and she knew something was wrong. Her family assumed it was an ordinary stomachache and gave her digestive medicine. 3 days later, she required emergency care. The doctor told the family they were fortunate to have brought her in when they did. Today, I want to explain what happened to Mrs. Kelly and, more importantly, how to keep the same emergency from happening to you. Please watch until the end. One sign is frequently overlooked, yet ignoring it for several more days can become life-threatening. I have worked in gastroenterology for more than 20 years. Every week, I encounter multiple emergency patients whose condition began with something that seemed ordinary at home: constipation. This is not routine constipation. It is fecal impaction, a large, hardened mass of stool trapped in the colon or rectum that cannot be expelled through normal effort. The name may sound simple, but a severe impaction that is left untreated can develop into one of the most dangerous gastrointestinal emergencies. Adults over 45 face increasing risk, particularly after 60. I want to describe the condition plainly because you deserve to recognize it before complications appear. The large intestine is approximately 1.5 meters long. One of its main jobs is to remove water from waste as it passes through. Under normal conditions, this happens in a steady rhythm. The colon absorbs an appropriate amount of water, leaving stool soft enough to move and pass comfortably. The difficulty is that the colon continues absorbing water for as long as stool remains inside. After 2 days, the contents become drier. After 3 days, they harden further. By 5, 6, or 7 days, the mass can become as firm as baked clay. Imagine shaping wet earth into a ball, letting it dry completely, and then trying to force it through a narrow pipe. Pushing harder does not make the object flexible. It may simply wedge it more tightly. A serious fecal impaction behaves in a similar way. Why does this occur more often in older adults? Several age-related and lifestyle factors can convey. First, intestinal contractions naturally become slower. Second, the sensation that signals the need for a bowel movement may become less distinct, so an older person does not respond as quickly. Third, many older adults drink too little water. This is common in Vietnamese families. Someone spends the day doing household work, caring for grandchildren, cooking, or watching television, and does not notice fluid intake until the mouth feels dry in the evening. Fourth, medicines can contribute. Some blood pressure drugs, pain medicines, sleep aids, antidepressants, anticholinergic products, calcium supplements, and even certain traditional preparations may slow the bowel or dry the stool. Fifth, physical inactivity reduces the movement that normally helps stimulate the colon. Sitting for hours after eating and resting throughout the day gives the digestive system fewer mechanical signals to keep contents moving. These factors create a perfect trap. It usually develops little by little rather than arriving in one dramatic moment. That gradual development is why families often underestimate the situation. One missed day does not feel alarming. On the second day, the person assumes the bowel will move tomorrow. By the third day, discomfort is treated with tea, coffee, or another familiar remedy. Meanwhile, the colon continues removing water. The condition changes in degree each day until an ordinary episode of constipation becomes a hard mass that no longer responds to ordinary effort. Now we come to the symptoms. And this is where fecal impaction often misleads families. It does not always present as simply being unable to go. It can imitate several other illnesses, and treating the wrong condition may make the blockage more dangerous. The first deceptive sign is diarrhea. That may sound impossible. How can someone have diarrhea and constipation at the same time? When a large, hard mass blocks the rectum, liquid stool from higher in the colon may still travel downward. Unable to pass through the center, it leaks around the sides of the impaction. The person sees watery stool and assumes the problem is diarrhea. They may take an anti-diarrheal medicine. This can be a serious mistake because reducing intestinal movement may leave the hard mass in place, allowing it to become larger and drier. If watery leakage appears together with several days without a normal bowel movement, a sense of fullness, abdominal swelling, or pressure low in the abdomen, do not automatically treat it as ordinary diarrhea. A medical assessment may be needed to rule out overflow around an impaction. Ask about the pattern, not merely what appeared in the toilet that morning. When was the last full, formed bowel movement? Has only a small amount of liquid escaped since then? Is there rectal pressure, nausea, loss of appetite, or a feeling that evacuation is incomplete? Those details help distinguish a possible overflow pattern from an uncomplicated brief episode of loose stool. The second unexpected sign involves urination. Some patients repeatedly feel the urge to urinate but release only a few drops. Others cannot urinate normally and assume that the kidneys or bladder have suddenly developed a disease. The rectum, colon, and bladder occupy a limited space within the pelvis. When the rectum expands around a large mass of stool, it can press forward against the bladder or urinary outlet. That pressure can disrupt normal urination. In severe cases, urinary retention becomes a separate emergency. The third misleading symptom is back, hip, or thigh pain. A person may believe an old spinal problem has returned. Apply a medicated patch, take painkillers, and lie down. In reality, increased pressure in the distended bowel can radiate into the lower back, pelvis, hips, or legs. New lower back pain that begins after several days without a normal bowel movement deserves attention. Do not assume automatically that it is only the spine. The fourth sign is especially surprising: sudden confusion in an older person. A parent or grandparent may begin speaking incoherently, forget the date, stare blankly, or answer a different question from the one asked. The family fears sudden dementia. Yet I have seen older adults regain normal alertness within 24 hours after severe fecal impaction was properly relieved. Pain, dehydration, sleep disruption, inflammation, urinary retention, and intense physical stress can all contribute to delirium in a vulnerable older brain. If an elderly relative becomes abruptly confused, ask about recent bowel movements while also seeking prompt medical assessment. Sudden confusion has many potentially serious causes and should not be diagnosed at home. Let us speak honestly about what can happen when impaction progresses. In the first stage, the bowel wall becomes overstretched, local circulation worsens, and the colon may lose more of its ability to contract. The abdomen feels tight, nausea, poor appetite, and exhaustion may appear. In the second stage, the effect extends farther through the colon. Abdominal swelling becomes visible, vomiting may begin, and the patient looks clearly ill. The third stage is the most dangerous. The intestinal wall can tolerate only a limited amount of pressure. If that threshold is exceeded, tissue may become injured or perforate. Pressure can also compromise local blood flow before a visible perforation occurs. Tissue deprived of adequate circulation becomes more vulnerable to ulceration and damage. This is one reason severe pain, progressive swelling, fever, or systemic illness should never be treated as a problem that can simply be pushed through at home. When the bowel wall develops a hole, stool, bacteria, and intestinal contents can spill into the abdominal cavity. The result may be peritonitis and rapidly spreading infection. This is not a situation in which an oral antibiotic at home is adequate. Emergency surgery may be required, and delay can greatly increase the risk of death. I am not describing this to frighten you. Knowing the warning signs can save a life. Seek emergency care immediately if the abdomen becomes rigid like a board or extremely painful when touched. If severe abdominal pain continues to intensify rather than coming and going, if fever rises above 38.5 degrees Celsius, or if there is repeated vomiting, complete inability to pass stool or gas, faintness, cold sweating, low blood pressure, extreme weakness, or drowsiness. Do not wait until morning or until another relative returns home. Do not keep adding home medicines. Call the local emergency service or go to an emergency department. Now, we can discuss action, but the first step is knowing when home care is inappropriate. suspected severe fecal impaction, significant pain, vomiting, fever, bleeding, marked abdominal swelling, urinary retention, or new confusion requires professional assessment. If there are no warning signs, and a pharmacist or clinician agrees that a rectal product is appropriate, follow the product label and medical instructions exactly. The source discusses adult glycerin suppositories, but the correct number and timing depend on the product and the individual. Using several doses together or repeating treatment without guidance can injure irritated rectal tissue and delay necessary care. The central rule is stop forceful straining. Strong, prolonged pushing does not reliably dislodge a hard impaction. It may force the mass more tightly against the rectal wall, aggravate hemorrhoids, cause an anal tear, produce bleeding, or raise pressure in the abdomen. If nothing is moving, stop, breathe, stand up carefully, and step away from the toilet. When a clinician has recommended a glycerin suppository, lying on the left side can make insertion easier. Use only an appropriate water-based lubricant if the instructions permit it. The rectal lining may already be dry, inflamed, and sensitive, so forcing anything into place is unsafe. Remain in the recommended position for the time stated on the package or by the clinician so the suppository can dissolve. Do not assume that an urge within 10 minutes means you should immediately stand and strain. The original source describes waiting 30 to 45 minutes, and after an unsuccessful first attempt, resting, walking gently for about 15 minutes, and drinking warm water before considering another attempt. For safety, any repeat dose should follow the exact package limits or advice from a pharmacist or doctor. If there is still no result, do not continue repeated self-treatment. Failure of an appropriate initial measure is not a personal failure. It is information that medical help may be required. People sometimes remain in the bathroom for an hour because they feel embarrassed to tell the family that nothing is happening. That delay adds exhaustion and raises the risk of dizziness or a fall when standing. Older adults should not lock themselves in the bathroom during a severe episode. Tell someone what is happening, rise slowly, and obtain help rather than repeatedly straining alone. At a clinic or hospital, professionals can assess the location and size of the impaction, the degree of bowel dilation, and the condition of the intestinal wall. An abdominal X-ray or other examination may be used when appropriate. Treatment may include a medically administered enema using a controlled solution and volume. In severe cases, a trained professional may need to perform manual disimpaction. Although the idea sounds frightening, the procedure is familiar in clinical medicine. A clinician uses a lubricated, gloved finger to break the hardened mass into smaller sections and remove them gradually. Depending on severity and the patient's condition, pain relief or light sedation may be used so the pelvic muscles can relax. This procedure should never be attempted by an untrained person at home. Performed appropriately, it can provide profound relief after days of pressure and pain. Resolving one episode is not the end of the problem. Without changes in hydration, movement, medicines, and bowel routine, impaction may return. A recurrence can develop more quickly because a colon that has been overstretched may remain sluggish. After treatment, ask what follow-up plan is needed. The answer may include monitoring stool frequency and consistency, adjusting a constipating medicine, changing the type of laxative, improving fluid intake, or evaluating another cause. The aim is not merely to empty the bowel once, it is to understand why the impaction formed and prevent the same sequence from restarting. Let us therefore focus on long-term prevention. Hydration is one of the most important factors. The large intestine removes water from stool. When the body is short of fluid, more water is conserved, leaving the stool drier and harder. Thirst sensation often becomes weaker with age. An older adult may already be dehydrated without feeling clearly thirsty. This is not laziness or lack of discipline. The body no longer sends the signal as strongly as it once did. The source recommends beginning the morning with a full glass of warm water before eating. Food and drink after waking can activate the gastrocolic reflex, a natural wave of contraction that helps move material through the colon. Warm water is not a medicine and does not dissolve a severe impaction. Its role is to support a regular morning routine and hydration before constipation becomes advanced. During the day, the source suggests 6 to 8 glasses of water. Personal requirements vary. People with heart failure, kidney disease, liver disease, or a prescribed fluid restriction must ask their clinician what amount is safe. Make hydration convenient. Place a small bottle or pitcher beside the chair where you watch television. Use a phone reminder if needed. Drink steadily rather than waiting until the evening. Movement is the next part. The bowel is muscular, and everyday activity helps stimulate it. Each time you walk, bend, or change position, the abdominal and pelvic muscles create gentle pressure that encourages contents to move. Remaining seated for 2 or 3 hours after a meal is a common habit that can make a sluggish bowel worse. Instead of immediately settling in front of the television, walk gently around the house, courtyard, or nearby lane for 15 to 20 minutes. If walking is difficult, sit safely in a chair and perform gentle side-to-side trunk movements or other exercises approved for your mobility level. Even modest movement can be more helpful than lying still all day. Medication review is equally important. Calcium channel blockers and other blood pressure medicines, opioid and some other pain relievers, sedatives, antidepressants, anticholinergic drugs, iron, and high-dose calcium supplements can contribute to constipation in some people. Do not stop any prescribed medicine on your own. At the next appointment, ask directly, could any of my medicines be slowing my bowel or causing constipation? Is there an equally effective option with less of this side effect? Doctors cannot always know which symptoms matter unless the patient raises them. Bring a complete list of prescription medicines, over-the-counter products, supplements, and traditional remedies. Laxatives also require care. Some older adults take a stimulant laxative every day as casually as a vitamin. Stimulant products make the bowel contract and may have a role in certain treatment plans, but frequent unsupervised use can create side effects and may mask an underlying problem. If you have used a laxative daily for weeks or months, discuss it with a physician rather than escalating the dose or suddenly abandoning a regimen. The goal is an appropriate bowel plan that may include hydration, dietary changes, movement, an osmotic agent, or another approach selected for your health condition. Biological timing can also help. The colon is often most active within 30 minutes after waking and again after breakfast. Use this natural window. Each morning, drink the advised amount of water, eat breakfast, and then sit on the toilet for 5 to 10 relaxed minutes. You do not have to feel a powerful urge before beginning. Do not strain. The purpose is to train a consistent routine. After 2 or 3 weeks, the body may begin responding more predictably to that schedule. This is a long-term, medicine-free strategy rather than an emergency treatment. Keep the routine calm and brief. Reading or using a phone for a long period can encourage excessive sitting and straining. If nothing happens after 5 to 10 relaxed minutes, stand up and continue the day. Return when a natural urge appears rather than forcing a result on command. Toilet posture makes a difference. A conventional seated toilet places the thighs at approximately a right angle to the torso. The puborectalis muscle can maintain a bend in the rectal passage, somewhat like a kink in a flexible hose. Raising the feet on a small, stable stool brings the knees above the hips and may straighten the anorectal angle. This position can make bowel movements easier for some people without medication. Choose a support that cannot slide, and prioritize safety when sitting down or standing up, particularly if you have poor balance. Perhaps you are watching not for yourself, but because you care for an older parent, grandparent, or relative. In that case, please understand that fecal impaction in a frail older adult rarely improves through silence and continued waiting. People who are bedbound, physically inactive, eating little, drinking insufficiently, or taking many medicines are at especially high risk. They may not mention constipation because of embarrassment, because they consider it trivial, or because they do not want to trouble their children. Caregivers can prevent silence from becoming danger by asking respectfully and routinely. A simple question about the last normal bowel movement can be included alongside questions about food, sleep, urine, and medicine. Privacy and dignity matter, but so does recognizing a change before pain, vomiting, urinary retention, or confusion develops. If an older relative has not had a normal bowel movement for 3 days, ask gently about symptoms. Encourage safe fluids if they are not fluid restricted. Help them stand and walk if their mobility plan permits it, and contact a clinician or pharmacist for early guidance. Do not wait until the 5th, 6th, or 7th day before seeking advice. The original source mentions using glycerin from the 3rd day. Because suppository doses and contraindications vary, confirm the specific product and plan with a medical professional. Early assessment is safer than repeated, unsupervised dosing. An ordinary abdominal examination and, when indicated, a simple X-ray can quickly provide useful information about stool burden and bowel dilation. Do not let embarrassment prevent the conversation. Discussing bowel movements may feel uncomfortable. The consequences of staying silent can be far more serious. Let us summarize the essential points. Fecal impaction is a hard mass of stool trapped in the colon or rectum that cannot be passed through normal effort. It develops when stool remains long enough for the colon to remove increasing amounts of water until the mass becomes hard and immobile. Adults over 60 face the highest risk, especially those who drink little, move infrequently, live with chronic illness, or take several constipating medicines. 4 signs are often misunderstood. Watery leakage may be overflow around an impaction rather than ordinary diarrhea. Difficulty urinating can occur when a distended rectum presses on the bladder or urinary outlet. Unexplained lower back or pelvic pain may come from bowel pressure. Sudden confusion in an older person can accompany severe constipation, dehydration, pain, or another urgent illness. Emergency warning signs include a rigid, severely painful abdomen, fever above 38.5 degrees Celsius, worsening continuous pain, repeated vomiting, inability to pass stool or gas, faintness, sweating, low blood pressure, unusual drowsiness, or marked confusion. These require immediate medical care. At home, do not keep straining. Do not automatically use antidiarrheal medicine for watery stool when an impaction is possible. Use rectal products only according to professional or package instructions, and seek care when initial treatment fails or any warning sign appears. For prevention, drink an appropriate amount of fluid, begin the day with water if medically suitable, walk gently after meals, review constipating medicines with your doctor, avoid unsupervised laxative escalation, establish a relaxed morning toilet routine, and use a safe footstool to improve posture. Digestive health is not a minor issue. It influences appetite, sleep, energy, comfort, mental clarity, mobility, and overall quality of life. Yet, bowel symptoms remain among the topics older adults are most reluctant to discuss. Today, we have spoken about them openly. You now know which signs require action and which habits can support prevention. This video provides general education and cannot determine whether your symptoms come from fecal impaction, bowel obstruction, medication, cancer, or another condition. Persistent constipation, a major change in bowel habits, bleeding, unexplained weight loss, severe pain, vomiting, fever, or confusion needs professional assessment. If this information helped you, press like and share it with relatives, especially families caring for an older adult at home. Leave your questions in the comments. I read them all. And if drinking water is safe for your medical condition, take a moment now to have a glass. It is a simple beginning for a healthier bowel routine. Thank you for watching, and I will see you in the next video.